this presentation, this course will be an extension, and it will be very helpful for the young ophthalmologists, whoever wants to start a private practice and scaling up their practice to an institute level. Because it's very important, because whatever the previous course was there, it's about already an established name. So now in this course, we will be telling about how to establish that. And these are certain like brick by brick you need to grow, and these are the individual bricks you need to know, you need to understand the nuances. You need to understand the nuances so that it can be helpful for your practice to grow, and you can scale up to those levels what you had seen in the previous courses. So with not further ado, we'll go to the first talk. First talk will be by the most promising. We see here, all the speakers are young entrepreneurs who have started their clinical practice like a small private practice, and they have scaled their practice to the level for last 10 to 15 years. And they all practitioners are individual practitioners who worked hard for last 10 years to grow to this level. So the first talk will be by Dr. Nikhil Gandhi, none other than, so he has a practice in a tier 2 city in Maharashtra, where he started with a small scale private practice, and now he has scaled up to a next level practice like an institutional practice. And he will be sharing his idea how to discover the initial measures to be pursued as a solo practitioners. Over to you, Nikhil.
Thank you, Praveen, and thank you, AIOS, for giving us the opportunity. So, as I can see, there are not much of the seats are quite empty, but I feel that those who are here, this topic would be definitely helpful for them. Discovering the initial measures to be pursued as a solo practitioner. So I do not have, this is a non-academic talk. I do not have any financial interest. It's my personal point of view, and not necessary for everyone to agree with every point. Other views are welcomed. So my practice is based in a tier 2 town called Akluj, which is 160 kilometers from Pune. I practice with my father, who is a general ophthalmologist, and my younger brother, who is a vitreoretinal surgeon. I'm into practice for past 1 decade. So before you start a private practice, we need to check on few things, like whether, whether you want to go and join the academic institute, whether you want to go and join the corporate hospitals or charity hospitals, or do you require further trainings. So before you enter into private practice, you need to check all these things. And also you need to see whether you are do you have the hard working capacity? Do you have the multitasking capacity? Do you have the, are you able to handle the stress? And whether you are good in communication skills. Because what I have seen is the surgeon who is very good in surgery is not able to, communicate with the patients, is not going to deliver what he is supposed to actually. So you need to check all these things into you before you enter into private practice. So the ABCs for starting a private practice is availability, behavior, and competence. So the success mantra is like you have to give balidan dena hoga. Basically, you have to sacrifice all the things, because you have to completely dedicate your time to the private practice. You just cannot say that friend of mine is taking off after 6 p.m. But then you have to sit into OPD in the initial times. So you have to sacrifice your what you can say where rest of the people do enjoy. So when do I start? Like, identify the sweet spot. Whether you are competent enough, whether do you have confidence, and whether you have completed your training, or do you really require any further training. So basically you need to find out the sweet spot. This is very important before you enter into, because I've seen most of the youngsters, what they do is they get into practice and then they feel that no, I should be doing my phaco fellowship or cornea fellowship or retina fellowship, and then they leave their practice, they go back and they come back. So this is not the way. Once you finish, you need to finish it, everything, and then you have to come and join start the private practice. So where do I start? Whether to start in the metros or bigger cities, yes, of course, you have big opportunities for expansion and collaborations, easy for premium practice, but there is longer incubation period, because most of us, everybody wants to migrate to the metros, what I've seen. But I would definitely say that, I have started my practice with my father in tier 2 city. It's a small town, like you can start in tier 2 smaller hometowns. There is less competition, high volume practice, you can build a high volume practice, and lower initial cost of investment, as you might be inheriting your parents' the property, and you can build a hospital over there. So you don't really have to invest into the land. So the success mantra I would say is Mera Gaon, Mera Desh. So, we should not be leaving our own town and going somewhere else, but I would definitely say that you need to stick to your hometown and start a practice over there. So Where to exactly start? Location, easy accessibility, preferably ground floor for OPD, and it should be good visibility, and there should be enough space for waiting area, and OT should be spacious. To begin with, keep it basic. You can rent it, lease it, buy it, or household property, as I said. Start on small scale and grow, gear up fast. Prime importance to quality of services. What I've seen is most of them, they try to compensate in the quality. They want to save the money, and they feel that, but that is not the way. It should be quality oriented. Only then you can build a practice which would last longer. So the success mantra would be start small and grow big. So to begin with, funding options like family funds, we are not good, our funding is not as good as Praveen, but of course you can have a family funds, bank loans, staggered or deferred payments, which most of the companies, they do let you, and IL bundling is one more option, but I will definitely not go into IL bundling because you always become, I don't know, like, you have to continuously buy their lenses, and you are always occupied with them. So I would definitely not go, but then this is one more option which might be good for some surgeons. So the funding options would be association with good CA before you start, because it's a huge investment, and good financial planning is a must in the initial period itself. So EMI would be a key to success, that is what I would say. So to begin with, minimum equipments required. There should be a good OPD slit lamp, ARK, biometer, and optional chair units, NCT, OCT, and YAG laser. These might be an optional things. But minimum required things are OT, microscope, phaco machine, and optional could be a modular OT with lamellar flow and type C vacuum autoclave. So I would say you should not be compromising on phaco machine, a microscope, and a biometer in the initial period once you're starting your private practice. So you need to build a team. Do not try to do everything by yourself. Develop management skills and recruit competent staff. Train your staff for multitask between OPD and OT, and continuous staff training is a must. Pay adequate salary. Usually what we tend to do is we try to hire cheaper labor, which will definitely yield a cheap things. Like if you pay them adequately, they'll work for you, and they'll see to, if a counselor is getting paid in a better way, he'll definitely counsel the patients, and you'll get good number of patients as well, like for the surgery. So I would say, koi bhi jang khali pet nahi jeeti jati. You should always remember this. You need to pay your staff adequately. So standardize the system, make protocols. Documentation is a must. Monitoring, computerizing is must, and ensure quality to ensure the quality. So marketing is no longer an unhealthy world. Ethical and appropriate marketing would be beneficial. Local, get associated with local bodies like IMA and Rotary, and awareness programs like glaucoma and diabetes mellitus, like screening for the diabetic retinopathy, and conducting multiple camps in and around your area. So in-house, you can do marketing for brochure, display of equipments and facilities best. Inbound would be using digital media and cold calls. And maintain patient confidentiality. Do not show aggression on criticism. Do not provide online treatment, and keep personal life away from professional life. So you have to, the patient should feel that, he is keeping all the samasyas in front of you. So, this would definitely, you would gain the confidence of the patient in you. So I would say, no goal is impossible, provided your efforts are sincere and your thoughts are pure. Thank you.
Thank you, Nikhil, for this wonderful start of this course. I think you have highlighted all the things which you need to have in a private practice and how to scale up. But what is more important is the cataract surgery. As you all know, 90% of your revenue comes only from cataract surgery. And unless until you are good in cataract, you cannot scale your practice to the next level. So we need surgeons, we need some surgeons to inspire you to become the next level cataract surgeon, and it is none other than Dr. Anurag Mishra, who is the star cataract surgeon in national level, who has been operating all over the India and all over the world. And he will give us his journey of cataract surgery from 2013 to 2024, and he will give us how to grow yourself as a cataract surgeon. So over to you.
Thank you so much, Praveen. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. This particular deliberation would be divided into two parts. One is the why of it, when I would be giving you the reasoning of why do you need to sharpen your skills, which are already phenomenal, I'm certain. And then in the next segment, I would try to give you some templates based on which you can chart your course to advance in sharpening your skills. So these are the two segments in which we would be talking about it. In every entrepreneur's life, if you look at the curve, there are three stages of any curve, a bell curve in particular. There is a stage where it goes up, that's a growth phase, and then it meets a plateau stage, and then it starts coming down. As an entrepreneur, you would definitely not like to see the right part of the curve, but remember, there is no part of that curve which is the plateau stage. If you have reached the plateau stage and you're not growing, then in financial terms and in industry terms, you're actually degrowing. So it's a constant growth compared to the last year's performance is what is going to keep you going. So how would you achieve that how would you achieve a constant growth is, you have to have a footfall of new patients requiring surgical assistance coming to you. And how would those new patient pool be built up is based on the word of mouth spread from the old lot. And how would the old lot recommend your name to the new lot who are aspiring to come to an ophthalmologist is based on visible and invisible factors. What are those invisible factors first? Are the soft skills of that institute and you as a surgeon. Communication, marketing, counseling, how established you are as a leader in your team, and punctuality. You don't keep them waiting. These are all invisible factors which ultimately play a role, but that's beyond the purview of this particular discussion. What we are focusing on is the hard skills, out of which the clinical acumen is something we'll leave aside. We will just focus on the surgical skills. Now, the patient always gets a good memory or keeps a good memory of the time he spent inside the OT based on the duration of the surgery and the finesse. They might not know that you're a fast surgeon, but ultimately it adds on to the experience that they've had when they were lying down on the table, because these are nervous moments, not only for the surgeon, but also for the patient. So this is the why part of it. Now let's come to the how, where I would like to give you some templates. The incision in phaco, I know there are plenty of people who would like to stick to the 2.8 platform, and some of you might already be doing it, but I would recommend that everybody transgresses to the 2.2 as early as possible, because remember, the centrard concept, even if it's to the tune of 0.5, does not hold good when the incision size is more than 2.4. So 2.2 platform is where you should be there, and when you're creating the incision, just remember that you have to make it as squarish as possible inside the OT. So there are a few mechanical factors playing a role in there, including the sharpness of the blades. Make sure that you've got all the ingredients right. The CCC, while we were students, while we were postgraduates learning the skills of CCC, we were told that CCC is a circle in which you have got 4 corners and then the parts which are running approximately straight. So these 4 corners you have to apply centripetal, then the other parts you have to perform apply a centrifugal force. Forget all that. CCC should be looked at a piece of canvas, which is the anterior capsule. You're given a pencil or a brush, which is a cystitome needle, and you have to draw a circle on that canvas. Forget about the factors, the counteracting factors, the acting factors, everything. Here is a canvas, and you're drawing a circle, which should be approximately 5, stationed centrally, and look circular. That's how aesthetically it looks good, that's how you become faster, and that's how the bag is ready for receiving the implants, premium or non-premium, whatever may be the case. Now, there are situations wherein the CCC becomes a little more difficult, and in fact, because of that apprehension, a lot of surgeons prefer to stay away from phaco just because the CCC is difficult, but these are not. Once you learn that, again, it's a canvas, make the canvas ready, such as this intermittent cataract, where the canvas is not ready for you to draw a circle on. So make it ready by pushing out all the fluid that's there inside, form the AC with visco, flatten it out, and then you can draw the circle, maybe with a cystitome, maybe with a pair of forceps, whatever is your instrument of choice. Next, coming to the hydro procedures, you've been told that you do multi-point, small injections of water, bellot the nucleus to express the fluid out. All that can be concised into one single step. Liberate the fluid from one side, express the fluid from the other, repeat the procedure if likely, and rotate the nucleus. I would always advise you to rotate the nucleus because that would ensure that the nucleus is free, and then you can proceed with your phaco procedures. It takes hardly 10 seconds. More than that, if you keep on liberating fluid, you know that you're not doing it properly. It shouldn't require more than that time. When we start our nucleus management, this is what we do. We draw, we first do the primary trench, then do the secondary trench, and then make it a cross and do a typical divide and conquer as we've been told. But what gets compromised in the process is the CDE count, which is essentially the energy that you're using in the process. As you grow from 4 quadrants to stop and chop, which I'm sure many people use, in fact, majority of the phaco surgeons in India, this is my experience, do retort to the stop and chop procedure, which is fantastic. I've got nothing against it, but the CDE count, the energy count just goes up a klitch when you do that. Your objective is from a 4 quadrant to stop and chop to arrive at this stage where you do a direct chop. I know there's a learning curve involved, but if you've got the mechanics right, then it divides very fast. And what you see in the process happening is you gain substantially when it comes to the energy expenditure count. This is an unedited video, which I'm showing to you. It's not even been sped up. 1.20, and this is not a very soft cataract, as you can see. 2.50 or 56 is the CDE count by the time we are through with almost half of the nucleus. The rest half will also come out. These are patients wherein you don't even need to give a postoperative corticosteroid. You can manage with a non-steroidal anti-inflammatory agent as well, which is basically, and then you go to these stages where you have all sorts of difficult situations peeping at you, a small pupil, a hard cataract. You don't need any expansion devices in there, just when your mechanics are right. Cortex aspiration, again, the teaching is you catch hold of the cortex and strip it to the center and see what you're aspirating. I would say that for 99% of the time, this is what you should be doing. Of course, if you are too adventurous, then you can do it with the phaco needle as well, but that should be kept for later when you really know that you're there right at the top of the platform to be able to do this properly. A lot of things are required. You need a very good microscope as well, which will give you the exact depth where you are. So these are little things which you can do to modify or enhance your finesse, thereby reducing the time, giving the patient less energy, keeping the tissues at ease, and ultimately they go back from you being happy with whatever they experienced, and the word of mouth spreads in favor of your name. Thank you so much. I'll not go to the IOL implantation, which of course you should be doing more and more under irrigation. And this is something I would encourage everybody to practice, because that's one thing wherein actually the technical expertise goes up a few notches. Thank you.
So thank you, Dr. Anurag, for this wonderful presentation on the techniques of cataract evolution, surgical evolution, how he learned the techniques and how we evolve as a surgeon. As I said, for conversion of a private practice to institution, it requires brick by brick, and these cataracts and individual cataracts are those bricks, and every eye deserves special attention and every eye counts. So next, as an anterior segment surgeon, we have no knowledge about what are the dynamics of a posterior segment, and a retina surgeon is very, very critical for your transition of your private practice. So in the today's world, you need a group practice. You cannot have individual, you cannot do all the things alone. You need a group a team where you have an anterior segment and a posterior segment. That makes your life easier and that gives you a good sleep. So Dr. Shweta will be speaking about retinal surgeon acts as a crucial support structure for anterior segment surgeon, and it's very, very important. Over to you, Shweta.
A very good afternoon to all the people present here. So today I'll be speaking on this topic, that the retinal surgeon acts as a crucial support structure. I'll show you how. So most of the anterior segment surgeons who plan to start their private practice pass out from reputed institutions doing very high volume of work, and they do really good cutting edge work. They learn excellent management skills in their field, but what they lack is they have limited exposure to the posterior segment. At max, they will dilate the eye, see the fundus in the slit lamp, see up, down, this side and that side, and then they will pose for surgery. They have very limited access to vitreous, like those surgeons who manage their own complications have some experience, but the juniors rarely do. So they will see that cases post-op 1, but in the long run, have you ever wondered what happens to the patient after PCR? Or what happens to a dropped nucleus or a cortical matter? How long does a CME take to heal, or how do we manage endophthalmitis? It might have bothered you for some days or weeks, but once it is out of your mind, it doesn't matter much. But once you are planning to start your own, it will matter, because you have been, you are going to be an entrepreneur. An individual who creates a new business, bearing most of the risks and enjoying most of the rewards. So now it will matter to you, because you will be responsible for each and every case you do, and the patient will come to you for life. So can you ever guarantee that you will never have a PCR or a phakia or CME? However good surgeon you are, you cannot guarantee these things to your patient. So self-awareness is very important. You should know your boundaries, and you should know when to stop. That's the first virtue of any surgeon having a complication. So in this context, I would like to put a word: anterior segment surgeons practicing medical retina. With the liberal use of injections, whenever an anterior segment surgeon sees a case like this, they inject, and they get really good results. So being over enthusiastic, they inject in cases like these. So what do you expect? There is obviously no effect, or it's going to worsen. So nowadays the patients are really demanding, so they will ask you every question why that they have not improved. So get your concepts right first. Even if your concepts are right, in a case like this where you have vitreous hemorrhage, giving an anti-VEGF will clear off the vitreous, or maybe the patient will improve. But in a case like this, where there is advanced PDR and you give an injection, you are going to do more worse to the patient than doing any benefit. So be careful in this aspect. And it's not rare that you have post-surgical surprises. In an era where we have 6/6 vision as a norm, getting a vision of 6/9 is also very traumatic. So in these areas where you have post-surgical surprises like macular hole or solar retinopathy or ARMD, then you need a vitreoretina specialist. Why? Because we are great counselors, because we are used to explain guarded visual prognosis to the patient. We will even explain guarded visual prognosis for the other eye of the patient also. And we will happily handle your complications. For example, I'll show you. This is a case of lens drop where there was a PPC and the lens dropped. So what we did is we cleared off the anterior segment, and inside we saw a really hard nucleus. So we put PFCL and we fragmented the nucleus inside without creating any more damage to the retina. We even lasered the barraged the small lattices which was present inside. So patient was high myopic, we did not put any IOL, and she gained a vision of 6/12. And this is a very critical case where the patient came to us. He was blind in both eyes, hand movements in both eyes. So the cataract was dense, as you can see. So we posted for cataract surgery. So you can see the suture temporally. When the phacosurgeon created the tunnel, he saw a zonular dialysis. And then he said, send it to the retina OT, and then we started the case. You can see how much zonular dialysis was present, so that the whole nucleus in toto came out. So before pre-op, I could see few membranes and vitreous hemorrhage. When I went inside, this was the eye, what I saw. So at this stage, what you do? You had just counseled the patient for cataract surgery. So what I did was, I just did a good vitrectomy, cleared off the tractional areas and cut the traction areas, and did a laser wherever I could do. Intraoperatively only I counseled the patient's attendant about the additional need of VR surgery. The patient was also blind in the other eye, so we decided to put at least an SF IOL. We did not choose iris fixated IOL because post-operatively sometimes the pupil doesn't dilate well, so it becomes very difficult for a retina surgeon to see or follow up the patient. So here we had created these side pockets, and then we injected a 3-piece IOL and secured put the haptics inside the side pockets. To our surprise, the patient gained a vision of 6/12 because the macula was on. Now the patient is having complication with the in his body due to diabetes. So he is blind in the other eye, but he is seeing something in this eye. Patient is now 6 months done. Patient vision is still the same. So here also the retina specialist helps you out a lot. So this case, what all the cataract surgeon dread. So this is a case of endophthalmitis. Patient was operated operated for cataract, and after 3 months he developed little bit reduction in vision. So patient was on long-term antibiotics and he was not improving. It was always 636. So we decided to go in and clear up the vitreous. You can see some colonies over the retina on the posterior pole. We did a good vitrectomy, induced the PVD and cleared as much as vitreous as we could. And then the patient responded to drops also. We kept the patient, we gave the injection to the patient, like 2 or 3 more injections, and the patient recovered almost to near normal vision of 6/6 parts. So we can be of great help if you are doing refractive procedures when, especially in myopics where we see them every 6 monthly, and if there are any lesions in the retina, we do a beautiful barrage. So basically we give the anterior segment surgeons the wings to fly. Sometimes the anterior segment surgeons who have VR support, they feel that they are burdened because we don't earn you direct money like the cataract does for you. But the fact is, if you don't have our support, you will be like any other tree in the apple orchard. But if you have a VR support, you will have an extra edge over others because your roots will grow deep and your institute will definitely have you will be able to provide better services to the patient. Thank you. At least if you can't afford a VR surgeon, at least be friends with them. Thank you.
So thank you, Dr. Shweta, for giving the insight how a retinal surgeon, VR surgeon helps you in your practice. But the most important thing, in a transition from a private practice to an institution, cataract surgery earns you money, the hospital earns you money, but the trust is always developed by the community service. So unless until you incorporate philanthropy into your practice, your institute or your hospital will never go to the next level. And it is very critical. And to highlight this thing, Dr. Atul Seth will be speaking on achieving a harmonious equilibrium between philanthropy and capitalism, which is a crucial endeavor in your practice. So over to you, sir.
Good morning, everybody, and let me start by thanking this lovely audience because I was fearing that it's going to be the 7 of us and maybe the audiovisual guys. So I think this is a thickly attended session. Thank you very much. So I think my topic is a rather philosophical kind of sounding topic, but it isn't. Actually, though capitalism and philanthropy are seemingly opposite things, they are pretty closely interlinked. Philanthropy, by definition, is actually giving yourself in some way for the underprivileged. Now, you can divide it broadly into the 3 T's. It may be your time, your talent, and your treasure. A treasure would be the money. And I know a lot of you would say, by time, talent, jo lena le lo, but don't touch the treasure. So even the first 2 T's are good enough. Believe me, there are a lot of challenges faced by a young private practitioner. Even if it makes me sound a bit old, I'll use the phrase in my time. So in my time, we had to start a practice. I was seeing Dr. Gandhi was showing the whole list. But at that time, we just needed a small premises, a slit lamp, an indirect and a direct ophthalmoscope, and a refraction set. And we had one man Friday who would double up as the receptionist, the OT assistant, the PRO, and believe me, sometimes even the driver. But the present day practitioner who starts is not so lucky. He's faced with a host of challenges. One is the patients expect 5-star interiors right from the beginning. We are facing competition from the corporate sharks, and if you're not planned enough, you may be gobbled up by them. These are these insurance companies who are becoming increasingly they are becoming a bigger nuisance. And actually, I would say giving us insulting rates, which does not justify the gigantic investment. And also, we have these educated, or should I say Google-educated patients who want the best technology for the least price. So it's not such a bad word, being capitalistic. In fact, we Bombay guys are always considered to be big capitalists, but it's not so. You can always incorporate philanthropy into that capitalism. By definition, it is someone who's running his own enterprise to make profit, and there's no sin about that. In fact, it is becoming difficult to generate profit, and this part has been covered by Dr. Gandhi already. I would just reiterate the same thing, that if you don't want to be gobbled up by a corporate, you start running your practice in a slightly corporate fashion, where you don't try to do and to be everything. And the people who are there to help you with the other things should be considered as a necessary expense. I think the capitalism has to be a compassionate capitalism, and it is not going to hurt you if you incorporate the low price segment into your practice. In fact, I would say that is going to help you justify your enormous costs by including those patients also into your practice. And one should also be, the new practitioner should be aware of, there are various schemes, and we should try and get empaneled onto them. Now, philanthropy. Philanthropy is a very heavily laden word, but it isn't. It's just, as I told you, the 3 T's. And in the initial years of your practice, what you can do is give your time and give your talent. So you could probably be a part of certain missions to the semi-urban and the rural areas on a periodic basis, where you go, you do surgeries, you have a local ophthalmologist and local personnel whom you train so that it's an ongoing process. There are these platforms like Orbis, and if you get a chance, you must offer your services. And as with time, once your practice is established and you're generally, well, you can say you're financially doing well, your place is doing well, then we should think about probably adding another charitable setup or a separate entity, and that's when we will have probably lesser time, lesser energy, but more money. So you can broadly, now we're talking about philanthropy and successful models. I don't think we can do it without bowing to these 3 doyens of Indian ophthalmology, who have created these 3 centers of excellence, of which we all are so proud. They have maintained excellence, and they have not compromised on quality in spite of the volumes. They are giving self-reliant service. They don't need, they're pretty self-sufficient, and they have raised the teaching standards, and they are producing such excellent and well-trained subspecialists whom we can really be proud of. But I would like to make a point that in the smaller places, all the focus is on cataract, and what I have seen is pediatric ophthalmology, glaucoma, and retina, they are a bit neglected. So these subspecialists should make an effort to offer their services by going to these places and training the local people also, so that it is an ongoing process. I have a periodic commitment to Bidra, Kutch, where I've been going from 2005, and it's a biannual commitment. And they really have absolutely no access to the pediatric ophthalmology specialists. It hurts to see simply treat, amblyopias, avoidable blindness, just because they have not been given or advised occlusion, it hurts. So I go there. My suggestion is have a set of like-minded friends. Like we take our own anesthetist, because it really wastes your time if you don't get an anesthetist there. And we do it free of charge, and these anesthetists being there helps us utilize every minute of our time. It's not that you're just giving. You go to these camps, you see such beautiful cases which you have never seen in your private practice. You learn to operate faster and with lesser resources. You get a strange sort of energy in these places. Of course, in all these, national and international trips, you see a different culture. You learn a different, you know that there's a part of India, like for me, I see a part of India outside Mumbai. It's really a learning experience and a deep sense of satisfaction when you come back and you see these corrected children. There are a lot of missions, and if you get a chance to go, with the Rotary International, mostly to the African countries. It's an excellent experience. I have been to Ethiopia, and we have an ongoing agreement with the Mauritian Health Ministry. Rotary sponsored it, and we go there. So I have this partner in crime, I would say, sorry, partner in philanthropy, Dr. Siddharth Kesarwani. So somebody whom you gel well with, we went there, and we really utilized our time, and in a way, we felt proud that we were representing India there. Training, we trained 2 doctors there, and now they send us the photographs. Thanks to this beautiful digital revolution, they are sending us photographs, and they send us pre-op, we suggest some things, we see the post-op photographs. So I think this teaching process also has to be focused on, not just doing the camps and then coming back. We should train somebody locally or invite them to come here, and we can train them in our setup and let it be an ongoing process. So here we have trained 2 doctors who have now taken over the mantle in the Subramania Bharati Eye Hospital in Mauritius. And I am sure I don't need to tell you that when you teach, you also learn. So it's that saying, when one teaches to learn, 2 people learn. I would like to end that, it is not so difficult. You should not wait till you get near your retirement to incorporate philanthropy along with your capitalistic approach. It should be in different fashions throughout as you progress in your career. And of course, again, the sharing your talent, or this, you can say teaching is the 4th T of that. And there's a beautiful saying with which I will end about teaching. It is Saraswati ke bhandar ki badi anokhi baat, jo baato त्यों त्यों बड़े, बिन बांटे घट जाते. Thank you.
So the next talk I will be speaking on, the aspiring for ambitious goals, the transitioning of your clinic to an institutional practice. So these are the bricks where you plan, you evaluate, you improve, you measure, and you execute. And these components are very, very essential for your transition from a small scale to a larger scale. So this is a treatise of my 12 years from a clinic to an institute. And it took me 12 years of hard work, and I have not gone to so many conferences, meetings, and I have worked for 12 long years to convert from the small practice to this level. So private practice or a clinic, here the regulations are very less. You can have a small chamber, you can have a rented chamber, you can have small physical space, and you can start with 1 room. But in an institutional practice, the regulations are increased, and you need more physical space. You have a dedicated team of, you need a dedicated team of admin, and you need to have an organizational structure so that the team, everything runs smoothly. So these are certain registrations which I had to get approval, like registration under Clinical Establishment Act, biomedical waste management, transplantation registration is very important because I'm a cornea surgeon, so I need a transplantation registration of my hospital, otherwise you can't do a transplantation. You need to have an NOC, no objection certificate from the fire. You need to have a drug bulk license. You need to have a drug retail license. And these are some of the licenses which I have showed, and much more than that. So these are certain things you need to know, because as a practitioner, we know only about ophthalmology. We don't know about these things. So these things are also important for your learning, so that when you want to scale up to the next level, these things will come in your way. And also narcotic license. And this is something organizational structure need to be there in your hospital, so that every person is given those jobs, so those jobs can be given, they have to do those jobs independently, so that your headache will come down. You can't handle all the things. You need individual people, different types of people, like for the community service, for the administration service, for the financial service, everything, so that everything will not come to your head and it will be very difficult for you to handle things. So the transition requires 3 important things: time, place, and person. So time, what matters is the most important is time. Time flies away. So if you want to transition, it's better to be sooner. The sooner, the better. So now you can see, like, you have so many corporate giants, so many hospitals in your vicinity. So you are in among the crowd. and you want to come out of that crowd, you have to stand apart. And that requires time, and that requires some form of knowledge regarding it. And why the time is required? You need to prepare. You need to grow. You need, as surgeons, we are like a students, like small children. When we give an exam, we may fail. And how to overcome that failure and how to lead. So what right now the situation is, the Tier 1 cities, the things have become so impossible. So it is possible that you have to go a little bit outskirts, you have to go to the Tier 2, 3, and 4 cities. That is more easier for you to start your practice and grow. Why the Tier 1 cities? Because it has a saturated healthcare system, very expensive infra, a demanding clientele, and the scope of growth is less because the physical space requirements, you may not have it. But in Tier 2, 3, 4, it's an unexplored terrain. You can go for the needy and obliged patients because those patients will be more obliged compared to the Tier 1 cities, and there is phenomenal scope of growth. So these are some advantages where there is a recognition, where there is a linear growth pattern, and you can do also community work. But the transition requires the skill and the academics. That's very, very important. So Dr. Anurag has already mentioned how a cataract surgery is very, very important. But during this course, like for example, I'm a cornea surgeon, and ophthalmology is constantly changing. There is advancing. What you had done in your PG time or in your fellowship time, things have changed over the course, and you need to learn again those things. For example, when I was a cornea surgeon during my fellowship period, so I had only knowledge about a full thickness penetrating keratoplasty. I had no idea about lamellar surgeries. But now you know that PK or penetrating keratoplasty has become obsolete. So now you have to go for lamellar keratoplasty, like deep anterior lamellar keratoplasty or a DSEK, depending upon the pathology where the cornea lies, in the pathology of the cornea. For example, if there is a posterior part of the cornea pathology in the endothelial pathology, you have to go for endothelial keratoplasty, and if there is a pathology in the stroma. So during this process, like DSEK also, it has evolution. Earlier, you used to do a thick DSEK, but now it has to be ultra-thin DSEK and DMEK. So during these new surgeries, when you learn new surgeries, you have surprises. You have failures. For example, when there is an endothelial keratoplasty, there is a lenticular inversion, lenticular dislocation. So in these patients, you need to counsel these patients. And during this process, you may have medico-legal issues, which will be dealt by Dr. Shishir in the next talk. Hence, again coming back, so what you need is the time. And the time and that enthusiasm, and because time is flying away, so you need time to learn that art. And academics play a very, very critical role for improving the visibility of your practice. It's a critical role in your career and increases your visibility. And how the academics can be divided in two important components. That's one is the conference presentation, which we are doing right now, CMAs, conducting CMAs, public forums, or webinars, all this part and parcel of the academics. But the second most important is the publications. You need to incorporate publications into your private practice, and then only you can scale your practice into institutional level. So you can start when you have no knowledge about publications, you can start with simple case reports. And once you see these cases frequently, you can publish them into like a case series. And then once you have little bit knowledge about the case series, then you can have a simple randomized trials. So for example, like this case, so where I had done a compressive sutures for an acute hydrops in keratoconus. So that time I felt it's okay, but I had documented that case and I thought of writing up that case. But in that process, I got a patent from the PubMed. So it was like a exhilarating experience for me. So some things at that point of time, you may feel that is very small and simple, but it may give you rewards later on. Case series, you are seeing frequently certain cases, document these cases, and then make it into a retrospective study of what you had seen and where are the failures and what are the failures that happened, and then you can publish those case series. And once you have the knowledge, simple cases, you can have a randomized prospective trials also. For example, in this paper which I had published, where I had compared phacoemulsification versus manual small incision cataract surgery in eyes with pseudo-exfoliation, which you see commonly in your practice in grade 2 and grade 3. And I could compare the visual outcome. So this can help you in publishing the higher level studies also. So to conclude, This is a small video. How to aspire for ambitious goal. Your transition requires an expansion of physical space, hire more healthcare professional, EMRs, expand your services, branding and marketing you need to improve your visibility, finances, establish a budget secure, community engagement, and finally, the training and development. So thank you for the kind attention. Final talk of this course will be, we need to know this is a very important topic. Dr. Shishir will be speaking. You need to have a medical indemnity. In your private practice, you may have failure and you may have medical legal issues. And this is very important for all ophthalmologists to learn how to protect yourselves. So over to you, Shishir.
Yeah, good morning, everybody, audience and the panel. So I'll be talking on medical indemnity. So to begin with, so no financial interest for this presentation. Are we burdened? So that is the main question. Are we, as ophthalmologists, burdened to give out, free service as well as get new technology? So yes, we are burdened. So there's a high cost of technology in ophthalmology due to the increasing competitive environment and social demand. You sit with some old instruments, somebody beside you will come and sit with more, expensive instruments. And we also are under pressure to progressively lower our costs to the consumer. And to keep costs down, there is always a tendency to do more and more surgeries and provide and give more and more free surgeries. So where we are, so according to the Consumer Protection Act in 1986, it had excluded free surgery service from the purview of the Consumer Protection Act. But now, according to the new rules, even though you are providing free surgeries, you are likely to be sued, or if anything goes wrong due to your negligence, you're likely to be sued, even if you're providing free service. So the lessons learned is that in India, there is a prevalent tradition of providing free service, and that has resulted in lowering of guard by eye surgeons. And also there is this mass surgery assembly called free eye camps, which sees that millions of people are being benefited from it. So due to, lowering of guard and doing these free surgeries and more number of cataract surgeries, now even the courts are putting an exorbitant penalty which is imposed by the courts, and this has also destroyed the career of many ophthalmologists. So the main thing is, I am a doctor, not a god, and that's what you have to keep telling yourself as well as to the patient. And so to safeguard yourself, you need three things: primary, secondary, and tertiary prevention. The primary prevention is better, cheaper, and more predictable than cure. So what is the primary prevention? Attention. So when a patient comes to your OPD, attend to them, attend to their complaints, train the reception staff to be nice and speak nicely. If you are having any doubt regarding any disease or diagnosis, get an additional opinion. Sometimes the patient may come saying that the other doctor who has sent the patient has spoiled his eye. Don't ever, tell anything against. Always appreciate your colleagues. And when you're admitting the patient or admitting them for any surgery, get their identification done. Behavior, you have to behave nicely when they present to you. You cannot be rude, or you cannot shout at them even though they seem a little bit frustrating. And always, after providing any service, doing any scans or even buying from the pharmacy, always keep the bills and provide them with the bills. So coming to C, communication is extremely important, and also you need to communicate with them properly, bring your point forward also, and be kind and tell them about what exactly the problem is. Take a consent before doing anything. Taking a photograph is also, you require a consent. When they come to OPD, take a consent that you will be doing some minimal procedures on them. Show compassion, do a proper counseling before surgery, explain the pros and cons, the complications which can happen at least minimally. And also, CCTV is very important in your hospital. Documentation is something which is going to save you when any medical legal case arises against you. You need to document each and every findings extremely properly, and should show your expertise, also the efficiency and ethics. Ethics is extremely important when you treat a patient. For example, a patient comes with you for LASIK, and you're doing LASIK, and even though the corneal thickness is less than 450 or 400 microns, so be ethical. No need to just because a patient is more demanding, no need to go and over the board and treat them as such. Show empathy, and also you need to, whatever equipment you buy, you need to insure the equipment also. So good faith. So nothing is said to be done or believed in good faith, which is done or believed without due care and attention. So even though you're doing in good faith, do it with due care and attention. So insurance, you need to get an insurance for yourself, the hospital, your staff, the instruments, and also ID proof for the patient like I mentioned before. So next is the secondary prevention. So secondary prevention is damage control. So once an issue arises, like a medical legal or something arises, you need to have damage control. You need to take advice from medical legal experts. Your associations like the AIOS body or your IMA, they can help you around with it. Then you need to negotiate with the patient party, their lawyers, and then you need to reach a compromise. So that is your secondary prevention. The tertiary prevention is your indemnity. So what is indemnity? So there are two types of insurance, general and life. So indemnity comes under your general insurance. So indemnity insurance are two types again, the professional which you take for yourself as an ophthalmologist, and then there is one for the hospital. So before that you need to understand risk. Risk is attached to all activities of life. It is an event which is harmful to someone, but rare, but does happen in reality. So do not practice without an indemnity insurance. That is a huge risk. So what is medical indemnity insurance? It's a contract under which the insurance company agrees in exchange for the payment of premiums to indemnify or protect the insured doctor because of his claimed professional negligence. So indemnity will compensate for harm or loss which you incur. So it is to protect the professional interest of the insured doctor, to arrange, conduct and pay for defense, and to indemnify the doctor. So it is a contract between you and the insurance company. You need to keep a copy of the policy, read the offer document carefully, and the insured pays premium in proportion to the amount of insurance as per the tariff. So sometimes if you, the insurance company will ask you for co-payment. For example, if you are in a court case and then the court has asked you to pay premium, asked you to pay 40 lakhs, the insurance company will say, I'll pay 30 lakhs for you, you pay the rest of the 10 lakhs. So that is co-payment. So don't agree for that. Read the offer document carefully before you go ahead and ask for the indemnity. So how much amount you need to insure yourself in an ophthalmic practice? So the minimum what they say is 50 lakhs premium. You can take 25 lakhs premium from two different insurance companies, but they say you need to go up to at least 50 lakhs to 1 crore, and if you're owning an hospital, you need an insurance coverage of at least 2 crore. You need a separate hospital and staff insurance of 1 to 2 crores. But the premium per year which you pay to the insurance company, it won't go beyond 40,000 per year, inclusive of the GST. So, and it must be uninterrupted. You can also get cheaper policies if you apply through probably through the IMA or the AIOS official bodies. They are also providing this indemnity insurance. So, in any hint or suspicion, or if you receive a complaint letter from the patient or NGOs or a lawyer from the court, you need to inform your insurer and get a signed and stamped acknowledgement from them that you have been sued or for negligence, and then you need to inform them, otherwise later they'll say that you didn't inform and things like that. So I'll just go to the new one. Yeah. So there is a new insurance concept which say that some private insurers, they give a complete risk management. They'll give you insurance for your doctors in your hospital, for the hospital, then Mediclaim plus vehicle plus residents plus etc. And they also have a 24-hour helpline. So retroactive date is the date when the insurance commences and continues uninterrupted should be clearly mentioned in the policy, and the policy period is 1 year. So this I already mentioned that the ophthalmologist needs to have at least 50 to, I'll just finish in a couple of slides, 50 to 1 crore insurance, and if you're having a hospital, you need to have a 2 crore insurance, which will be inclusive of your GST. So sometimes they also provide in ratios, that is 1:1 or 1:2. Sometimes the insurance company will say, sir, we'll provide you for insurance for 2 cases. So if they're providing you 1 crore insurance, it means 50 lakhs you can fight 1 case, 50 lakhs if you have been sued for another case. So never accept that. Always take a 1:1 coverage, although the premiums may be lesser, but always go for a 1:1 coverage. So to sum up, have an indemnity 50 lakhs to 1 crore. It should be an uninterrupted cover till you stop practice. Do not publicize or mention that you have an insurance cover. Remain within your field. Don't provide opinions beyond that. And inform the insurer when you anticipate trouble and take their stamped acknowledgement. So these are some of the exclusions: intoxicated doctor, criminal cases, defamation, third party, etc. and also natural disasters, radiation use. These are few of the exclusions. So there are a lot of cases which have come and doctors have been sued and the courts have asked for a higher compensation, especially cases with ROP, etc. And you need to learn from those cases. These are easily available online on Indian Qanun. Thank you for your attention.
So thank you, Dr. Nikhil, Dr. Anurag, Dr. Atul, Dr. Shweta, and Dr. Shishir for this wonderful course. I think we would like to repeat this course in the near future conferences. And anybody wishes to ask any questions or any doubts regarding this, regarding the topics which we have just covered, because it has covered A to Z of transition from private practice to institutional. I think it's very, very important for the youngsters who wants to start their practice. So once I think there is no more doubts, we'll call the end of the day. And thank you for patient hearing and staying till the end. So I would request all the speakers to come forward. We can have a short, we can have a photo.